problems. A mild fever, fatigue, weight loss in April, left upper quadrant heaviness, probably a big spleen issue, confirmed by CT, and large retroperitoneal adenopathy with bilateral inguinal lymphadenopathy. A patient has a compromised platelet count. Bilirubin is normal with normal liver function studies. And the patient reports that pretty sure he's been over the spleen for a long time, not yet defined. Due to poor insurance coverage and distance from the center, he was started an FCR in 2017 and tolerated 4 cycles with some of the common problems that we can see with FCR and growth factor coverage. He normalized his lymphocytosis, was MRD positive, and a whole body PET CT scan demonstrating significant lymphadenopathy with a biopsy of his bladder wall and a kidney lesion, now showing a diffuse large B-cell lymphoma. He went on the regimen we heard of before, the dose-adjusted our EPOC. His disease is unmutated IgH status, and now we have some comorbidities presenting at this point in his life, and he's being considered for an allogeneic or CAR T-cell study as part of a treatment. Challenges remain with insurance plans, which we all see. We'll go back. Comments from the panel.
So we chose the regimen because it's effective in diffuse large B-cell lymphoma, and it forced him to be in the hospital. So he was approved, believe it or not, for both venetoclax and ibrutinib. He still has the venetoclax at home, but I couldn't find any use in Richter syndrome with ibrutinib and chemo. His lymphoma burden was very high. He was supposed to have a PET scan this Friday, but again, he took his insulin and it wasn't done, so it'll be done this Monday. So I'm hoping he has a responsive disease. So after cycle 2, he was started on ibrutinib, but only for 15 days instead of the full 3 weeks after the epoch to try and mitigate against the neutropenia. And he was allowed to use the OP and Neulasta on-body injector because we did it at our place. So the question for the panel, besides all his comorbidities, is what to do next and where would you use venetoclax? He was rejected from any trials we had because of the Richters and the CLL, and I don't think I can get him on a CAR T regimen. So for now, we are working on getting an allo transplant, but I want your input as to how best to debulk him. And based on what you said about the response of combining venetoclax with ibrutinib, why not do that? I was afraid to do it initially with a lot of this lymphoma burden.
Start. Okay, so historically, if you have a patient who is otherwise healthy, we're not talking about your patient, otherwise healthy patient with transformed lymphoma, which is Richter syndrome, you would give an anthracycline-based therapy, try to put them into as much tumor control as possible, and then take them to an allo transplant, exactly as you were thinking. Obviously, here are certain problems with this patient in which you were not able to do that. I think if the patient was not able to complete the EPOC treatment, that was one of the issues, right? I mean, the FCR. At this time. I mean, okay. And the restaging scan, is it showing progression or response? We don't know that. I mean, if there is a response, I would still try to continue and see if he can go to an allo transplant or CAR T. If he doesn't have a response, or if he cannot proceed to a allotransplant or CAR T, I mean, continuing or starting with venetoclax may be a good idea because there are patients with Richter syndrome who respond. No, I mean, for example, I have a patient now with Richter syndrome, almost the same story. She could not tolerate CHOP. R-CHOP I gave one cycle about a year back, from more than a year. She could not tolerate, she was in the hospital with comorbidities. So I started venetoclax. She did have 17p though. And she's more than a year, complete remission. Even marrow doesn't have any evidence of CLL. Actually, it's being presented as a poster in the Pan Pacific, I think, coming up in 2 weeks. I think Dr. Zelnis will see the poster there. I'm sure he will be there. So I think there are responses noted. I'm not sure how long it will last, and there is no reports other than case reports with that situation. So.
Yeah, so Richter transformation remains the most challenging disease in the CLL world. I think all the other diseases of the CLL we have good handle on, except for Richter transformation. So I think the most regarded way to go forward is exactly what you're taking. Is basically if it's a young patient that can tolerate intensive immunochemotherapy, is to use that as an induction therapy in hope that to achieve a good response. If you're able to achieve a CR or near CR or pretty good disease control, then going into allogeneic stem cell transplant. I think that's really the only pathway that has track record of giving potential long-term remission. However, if he's not able to achieve a good response, if he's seemed to be a chemorefractory, then agree that considering the ibrutinib venetoclax combination, even though there's really no good data, it's all anecdotal data, but especially for a patient who's never been exposed to those agents, I think there's still potential chance for them to respond. And then I think CAR T will be, if you can find a CAR T trial for Richter patients, insurance. What clinical trial? Oh, really? Okay. So it's not a very motivated patient. Then you have to think about allogeneic transplant. It's going to be also challenging, right? Yeah. But I think those are the pathways.
No. It's that simple. I mean, we know that, from the Cavalli study where we combined R-CHOP with venetoclax, there was substantial excessive toxicity. This was not easy to do. The study of dose-adjusted EPOCH plus venetoclax hasn't been started yet. I'm concerned about toxicity there. This is not necessarily a proven regimen. If the patient's responding to dose-adjusted EPOCH, don't mess things up by getting unusual toxicity. It's already had plenty of toxicity, and by adding venetoclax, you're going to increase it, I promise.
Cytopenias is going to be a major problem. Yeah.
Right. So if he's responding, if that PET scan Monday looks great, try to get him to allotransplant ASAP. Do you have a donor lined up?
I've been away for a month for medical reasons, so I think we're working on it.
Yeah. So because that's. Yeah. So that's one of the things you want to do is make sure, because when he's ready to go, he should go. The other thing where there's some data that's been presented is ibrutinib plus pembrolizumab. However, I have to say that even though the early studies suggested activity in Richter syndrome, most of us have been for lots at home. So I don't know why those few patients responded who did, but I don't think checkpoint inhibitors is a big win. Interestingly, Anthony Mato has a study with TGR and a checkpoint inhibitor and ublituximab, and actually there's been a pretty nice response rate. Half of the patients with Richter's have responded. So if he's not responding, if you can get him motivated, there's clinical trial options, but ideally he's responding to the dose-adjusted EPOCH, and you get him to transplant as soon as possible.
Just a quick question on Richter's. Are these patients, what's the distribution between GCB and ABC?
They're all non-GCB.
So is it worthwhile checking for whether they're GCB or not?
He's non-GCB.
No, I know, but in practice, should we be?
Oh, so there's a very small fraction of Richter's that is independent of the clone. So there are two types of Richter's transformation. There's independent of the clone, and then there's dependent on the clone. If it's dependent on the clone, it's 100% non-GCB because CLL is a non-GCB B cell. The rare cases that have an independent, those are actually the patients who do well with treatment, and you sort of know them when you meet them because they tend to have localized disease. They don't have the, what was described, the reticulum cell sarcoma, this, big systemic disease. They actually tend to have more localized disease. I actually find that doing, if you know what their IGHV rearrangement is of their CLL, I actually recommend testing the IGHV rearrangement of the large cell lymphoma to see if it's clonal or non-clonal. We do that on a routine basis.
So if the PET scan shows that he's not responding, obviously the options are try to see a clinical trial. I think PI3 kinase you haven't tried in yet, right? I don't think we know how PI3 kinase alone will be useful in the setting of Richter syndrome, or one of the newer antibodies which Dr. Ma mentioned, like umbralisib, which is a PI3 kinase, and oblituzumab, which is the anti-CD20 antibody, the TG Therapeutics. They have the trial combination. I'm not sure if they take transformed Richters. I know they take diffuse large B-cell with follicular background.
There's something being planned for their upcoming trials. They will be combining those.
Okay, we'll go on to the next case. Thank you. Dr. Amin has a CLL case, which is the focus of this. This is a 68-year-old with RI stage 2 CLL with bulky adenopathy and splenomegaly. He's treated with arbendamustine. Didn't do well with the R portion of this in second infusion, and the treatment had to be stopped. 72, presuming he had some benefit from the original therapy, Dr. Amin is here somewhere. He's treated for 3 years with a SYK inhibitor on a trial with a PR. 75. He's treated with Gazyva obinutuzumab, but has an infusion reaction. And now at 75, he moves on to Imbruvica with a PR, but now has recurrent atrial fibrillation and a bleeding problem with melanotic stools. What do you do next with your Imbruvica?
So before we get to the what to do now, just a little mention about what to do earlier. As everyone knows, that virtually all infusion reactions to anti-CD20 antibodies are with the first cycle. Then it tends to be less or not at all with the second and subsequent cycles. In about 3% of patients, it gets worse with subsequent cycles. Those are the patients actually who are rituximab allergic. The initial infusion reaction is not an allergy, but a few percent will be allergic. Those patients, at that time, you can typically switch them to ofatumumab or obinutuzumab, and they will not react in that subsequent thing. Now, when they got obinutuzumab and had the grade 4 reaction, do we know what the white count was?
The white count was about 20,000 at that time.
Yeah. The recommendation for obinutuzumab in all CLL patients, 100%, it's not count dependent, is that patients receive 100 milligrams on day 1 and 900 milligrams on day 2 of dose 1. And that's to help mitigate the infusion reaction. Infusion reactions are, when you get to know the drug, they're not so bad. But when you're first using obinutuzumab, the obinutuzumab infusion reactions are pretty difficult. One of the tricks is pre-medicate with prednisone 50 milligrams the night before, 50 milligrams the morning of, and 50 milligrams immediately prior to. You'll never read that on a package insert. It works great. And it's a really good trick for reducing the infusion reaction. But in CLL, 100% of the time it should be split into the 2 days, and that will help mitigate the infusion reaction. So now we can go back to what to do next.
And if I can follow up on Dr. Selner's point, it's also important if you have a good allergy and immunology group close by. In our institution, we have a very good and very aggressive allergy immunology group. In the last 10 years, I don't remember any patient I had to give up on rituximab or the other anti-CD20 antibody. In fact, even last week, we had a patient who was admitted to MICU for 48 hours, gave it. And subsequently, what happens is they will reduce the time, and then the second dose, we may give it in the regular floor, and the third dose in the outpatient setting. I have patients coming from 2 and 3 hours away because of the specific question. Because some of these patients, you really don't want to give up on rituximab, because it's not just rituximab, they are going to be eliminated as allergic to many of the anti-CD20 antibodies. So I certainly would try and see if there is a desensitization protocol you may be able to utilize in your allergy immunology somewhere close by.
So getting to your question, finally. All right, so what you're indicating is that this patient seemed to have developed some potentially related adverse events related to ibrutinib, including atrial fibrillation. He's also having melanostool, which may or may not be related due to ibrutinib, but at least you can say that he cannot be anticoagulated and have ibrutinib on board. That would be too much risk of bleeding, right? So apparently he has to be stopping the ibrutinib and think of something else. So what are the options? I would say so it sounds like he's stopping ibrutinib due to adverse events, not because of progression. So apparently he's still responding to the BCR pathway inhibition therapy. So you can think about changing to a PI3 kinase inhibitor, such as adalimumab. There has been study using adalimumab plus ofatumumab. So following up to their comments, that actually there is actually established publication for Waldenstrom patient, for example, who often you can see intolerance of rituximab. And many of those patients are able to tolerate ofatumumab. So you can think of using that combination instead of the traditional combination of adalimumab plus rituximab. So that's one option. The other option is that now that venetoclax plus rituximab just had expanded approval, so and it's definitely for relapsed CLL patients, it's definitely a potential option. So I think one of those two should be.
Or just single agent venetoclax is another option. It's worth knowing why the patient had melena, if a colonoscopy is unremarkable, well, then you're stuck because you have no idea, and it's probably an AVM, and you'll never figure it out. But if there's a specific lesion that is bleeding and it can be removed, then you really can think of treating with ibrutinib and an anticoagulation. Everyone probably has their own favorite. My favorite is using apixaban for management of AFib associated with ibrutinib, and that's because it has the lowest bleeding risk. So I use, in the patients who develop atrial fibrillation, I call the cardiologist, they tell me to do something, and I say, oh, by the way, you have to start them on apixaban, and they say, fine. So they manage the rate and everything else, but I manage the anticoagulation, and that's my preference. I don't know, what do you guys use?
And I just want to mention 2 points. One, of course, following upon what you said, I just want to emphasize that anticoagulation or bleeding is not a contraindication for starting or continuing ibrutinib. And even the package insert, I think anticoagulation is not considered as a contraindication, but caution is advised, and obviously you have to monitor very closely. And I agree, I mean, if you can identify a lesion that is bleeding and stop it, this patient could go back on that with the appropriate anticoagulation, whichever is your choice. The second point I wanted to bring up is just because a patient on ibrutinib developed atrial fibrillation, we should not be saying it is the ibrutinib that caused it. I just had in the last 2 weeks an experience of an older man whom I started ibrutinib, and I think after 4 weeks he was diagnosed with AFib in a local ER. He went there with palpitation, and of course, everybody thought it is one of those 10% patients or 8 to 10% patients who develop atrial fibrillation on ibrutinib, and he stopped. And I got my cardio-oncologist on the case, and she did all the workup and said she has long-standing disease, cardiomegaly. This is not something new. So I think it's also important to just not label ibrutinib cause that just because we diagnose it after the patient was started on that.
One more little pearl about anticoagulation. There's anticoagulation and then there are antiplatelet drugs. Thou shalt not combine ibrutinib with clopidogrel and aspirin. Very bad idea. So if someone has coronary artery disease and they have an acute coronary thing and they have to get a coated stent, which I always beg the cardiologist not to use a coated stent, but if they insist they have to use a coated stent, that is a reason to switch and discontinue ibrutinib. You cannot use ibrutinib with clopidogrel and aspirin. It will unequivocally cause horrible bleeding. The risk is very high. That's just a little pearl.
Thank you. Are there any other general questions? I want to respect everybody's time. I want to thank you for your attendance and your attention. I'm hopeful that we'll be able to have other events in the future that people will find useful. Please remember to fill out your email